So the objectives of the talk are to learn some imaging features of common primary intraaxial brain tumors in adults on both CT and MRI, to see some examples of conditions that may mimic intraaxial brain tumors, and then to learn typical imaging appearances of intraaxial brain metastases on CT and MRI, and see examples of conditions that may mimic metastases. So an outline of the talk, I'm going to talk about a few of the more common primary brain tumors. So oligodendroglioma, astrocytoma, and glioblastoma, as well as lymphoma, and then a few things that can mimic those tumors. And then I'm going to talk about the imaging appearance of metastasis and some things that can mimic metastasis. So some important features of primary brain tumors that I want you to remember and think about are listed below here. So we have some things that are suggestive of tumor if you see them. One of those is mass effect, and that's something that's important to see with tumors. One of them is vasogenic edema. And then another thing you can look for is replacement of the normal tissue architecture in the tumor. There are a few other things that can give additional information about the tumor. So restricted diffusion, enhancement, calcification, hyperattenuation on CT, and looking at the tumor margin. Is it distinct or is it indistinct? So since we're talking about intraaxial brain tumors, I just want to remind everyone what it means, intraaxial versus extraaxial. So here's a diagram taken from a book, and we have a drawing of the brain. And here we have cortex, and centrally we have white matter. Now an extraaxial tumor arises outside of the brain parenchyma. So here we have an oval-shaped tumor, and this is arising outside of the brain parenchyma, and it's displacing the brain tissue inward away from the tumor. It's buckling the cortical gray matter. That's a sign of an extraaxial tumor. An intraaxial tumor arises inside the brain parenchyma, and that's going to be surrounded by brain parenchyma, and it's going to expand the white matter, and the white matter will wrap around the tumor. So to start with primary brain tumors, here we have a few examples of different primary brain tumors. The WHO grading system was just updated in 2016, and this is a list of just a few of the tumors that are listed in the WHO grading system. I'm going to primarily focus on the diffuse astrocytic and oligodendroglial tumors. And if we zoom up and look at that list of tumors, we have astrocytomas, glioblastomas, and oligodendrogliomas are the three main ones that I'm going to talk about. Glioblastomas are very high-grade tumors, so they have a higher WHO grade. It's a grade 4, which is the highest grade, the most malignant tumor. Astrocytomas and oligodendrogliomas can be either grade 2 or grade 3. A grade 2 tumor is going to be just a standard oligodendroglioma, and if it's grade 3, then we add the word anaplastic. So anaplastic oligodendroglioma would be a grade 3, anaplastic astrocytoma would be a grade 3. Some imaging clues that you can look for that I had listed earlier, but here they are again, are mass effect, replacement of normal tissue architecture, indistinct tumor margin. If we see that, it suggests an infiltrative glioma. If we see edema with these tumors, the edema is going to be vasogenic edema and not cytotoxic edema. If we see restricted diffusion in the tumor, that correlates with a higher grade. Enhancement may or may not be present in these tumors. And if we see calcification in a tumor, then we need to think about oligodendroglioma. That's going to be the most likely diagnosis. Similar to restricted diffusion, if we see hyperattenuation on CT, that suggests hypercellularity in a higher grade tumor. So here's an example of mass effect, and this is not a tumor. This is a hematoma, intraparenchymal hematoma. It's very dense on the CT scan, acute hemorrhage, but things other than tumor can cause mass effect. So hematomas can cause mass effect. And here we see this patient's head CT before the hemorrhage happened. So we happen to have a head CT that we did a few months before the hemorrhage occurred. And you can see what happens when you introduce a mass be it a hematoma or a neoplasm, a tumor, into the brain. What it does is it causes mass effect and it displaces structures. So here we have midline shift. The midline structures are shifting to the right. They're being displaced away from the tumor. We also have sulcal effacement. So here previously we saw CSF in the sulci, and now the CSF is gone. So that's sulcal effacement. So those are the signs that we look for with mass effect. Here are some gliomas with mass effect. So these are all T2 weighted images, and these are different tumors. Here's a tumor in the right temporal lobe, and it's causing mass effect. So you can see it's expanding the temporal lobe. It's displacing structures. It's displacing the midbrain here, the mammillary bodies and the hypothalamus here. It's displacing the frontal lobe here. So this is mass effect associated with a tumor in the temporal lobe. Here's a tumor in the frontal lobe that's causing mass effect. So here we have displacement of the interhemispheric fissure to the right. We have some sulcal effacement. We have effacement of the frontal horn of the lateral ventricle in this location. And then here's another tumor with mass effect. So this is a large tumor. It's causing midline shifts. So the midline structures, the septum pellucidum, are shifted to the right. It's effacing the left lateral ventricle, and it's effacing the sulci. Next, we're talking about replacement of normal tissue architecture. So here's a few different tumors, and they're all replacing the normal tissue architecture. So in this tumor in the left frontal lobe, if we look at the signal of this tumor, you can see it's heterogeneous. So we have some areas that are bright, some areas that are darker, and it's very heterogeneous. And we don't see the normal cortex and white matter underlying this tumor. It's been completely replaced. In this tumor in the right sylvian region, we can see kind of a similar thing where we don't see the normal cortex and subcortical white matter. We have this thickened intermediate signal tissue that's replacing the brain parenchyma in this area. And then in this third tumor, we have, again, replacement of normal brain parenchyma. So we lose the normal cortex in this area, and we have homogeneous hyperintense signal. Another thing we look for is indistinct tumor margin. So tumor in the left frontal lobe in this location, the tumor is hyperintense, bright on T2. And if we try to find the margin of the tumor, especially in this area, it's very indistinct. So you can't draw a line exactly at the margin. It blends into the normal adjacent brain parenchyma. This tumor in the right parietal lobe, it's also bright on T2, and as we look for the margin of the tumor, you can see that it's blending in with the normal brain parenchyma. We can't draw a distinct margin around the tumor, and that means that it's an infiltrated tumor. And then with this tumor, same thing. So if we look for a margin, we see that the bright signal is blending in with the normal brain parenchyma surrounding it. So indistinct margin with this tumor. Another thing we look for is vasogenic edema. So T2 flare image here, and surrounding this mass, we have vasogenic edema. And as a reminder, vasogenic edema affects the white matter and it spares the cortical gray matter. So we have on flare bright signal in the white matter, but normal signal in the cortex. And same thing posteriorly here, bright signal in the white matter and the cortex is spared. With this other tumor, we can see vasogenic edema in this location. So we have bright signal, that's the edema in the white matter, and it's sparing the cortex. Here it is on the head CT. So we have a mass in the cerebral hemisphere, and there's the surrounding edema, which is hypoattenuating or dark on the head CT. And this is infiltrating the white matter, and it's not affecting the cortex. The normal cortical gray matter density is preserved. So that's vasogenic edema. And vasogenic edema is something that we see with tumors, we see it with abscesses, and even with hematomas, but we don't see it with stroke. With stroke, we see cytotoxic edema, which affects the gray matter and the white matter, so we lose the gray-white differentiation with cytotoxic edema. Next, we look for enhancement. So here are a few different tumors that have enhancement. This tumor has heterogeneous enhancement on the post-contrast images. Some areas are not enhancing, some are enhancing. This tumor has peripheral enhancement that's heterogeneous, and we have central non-enhancement or necrosis in the center of the tumor. On this image, we have some nodular enhancement, multiple nodules of enhancement, and it's relatively homogeneous. Restricted diffusion is another thing we look for in these tumors. So these are all ADC maps, apparent diffusion coefficient maps, and we look for dark areas that have restricted diffusion. So here you can see a band of dark signal in the tumor that's about equal to brain parenchyma in intensity, and that's restricted diffusion in the tumor. It's fairly mild. Here's another tumor that has restricted diffusion. So this area is dark on the ADC map, and that's restricted diffusion. It's a little bit darker than the brain parenchyma. And then finally, we have a tumor with very intense restricted diffusion here that's much darker than the brain parenchyma. Most of the tumors that we see that have restricted diffusion are going to be of the milder variety, but some will have this intense restricted diffusion as well. On CT, we can look for hyperattenuation in the tumors. Most tumors are going to be hypoattenuating, but sometimes we'll see hyperattenuation. Like in this case, we have a tumor in the left frontal lobe, and it's brighter than the adjacent brain parenchyma, hyperattenuating. This tumor has low density centrally, but it has hyperattenuation along the margins of the tumor. And then this tumor has a nodular area of hyperattenuation. And what this hyperattenuation means is that the tumor has hypercellularity, so it has very densely packed cells, and that correlates with a higher grade in gliomas, and it's something that we also see in lymphoma. Another thing that we look for is calcification. This is a little bit less common. We don't see it very commonly, but when we do see calcification in a intraaxial brain tumor, we need to think about oligodendroglioma because that's the most likely diagnosis. Here we have a mass in the left frontal lobe that's mostly low density, and then we have curvilinear calcification within the mass, and that's an oligodendroglioma. Here we have a mass that's fairly low density on CT with areas of internal calcification, another oligodendroglioma, and then finally we have another low density mass with areas of ribbon-like calcification, and that's an oligodendroglioma. Okay, so let's go through some cases now and look at some different brain tumors. So here we have a 36-year-old male who presented for stroke alert. So he came in with neurologic deficit, and the clinicians were concerned about stroke. Now, stroke's pretty uncommon in young people in their 30s, so when you see that, you need to be suspicious that maybe it's something else going on, maybe not a stroke. So here's his head CT without contrast. We see a low density mass in the left frontal lobe, and we see calcifications. Now the mass has mass effect, so there's effacement of sulci. Here we have CSF in the normal sulci, and here we have effaced sulci. And we also have vasogenic edema, so if you look at the margins of the mass, here we have low density in the white matter, but preservation of the normal cortical gray matter. So that's vasogenic edema surrounding the mass. Here we have T2 weighted image and T2 flare, and we have a mass in the left frontal lobe. So this mass has mass effect. We again see the sulcal effacement. The CSF is being effaced from the sulci. We have vasogenic edema surrounding the mass, so this bright signal that's extending out into the white matter with the preserved cortex, that's vasogenic edema. We have the replacement of the normal tissue architecture, so that kind of heterogeneous, abnormal appearing architecture of the tissue within the mass. We don't see the normal cortex and white matter underlying this tumor. It's replacing the brain parenchyma. And we have indistinct tumor margins. So if we try to find the margin of the tumor, it's a little bit fuzzy. We can't quite draw a line exactly on the margin of the tumor, indicating that it's an infiltrating tumor. Here we have pre-contrast and post-contrast T1 weighted images. And if we look for enhancement, we don't see any significant enhancement. There are a few vessels here, little dots of enhancement, but there's no significant enhancement in the tumor itself. On diffusion-weighted imaging, there's no restricted diffusion in this mass. So the mass is about equal to adjacent brain parenchyma on DWI, and on the ADC map, it's brighter than the brain parenchyma. So that means no restricted diffusion. And this is going to be a lower grade tumor. This is a WHO grade 2 oligodendroglioma. Next here, we have a 27-year-old male who presented for stroke alert. So again, they presented with a neurologic deficit. And if you interview these patients with the brain tumors, sometimes they do present with neurologic deficits, but they're typically not an abrupt onset neurologic deficit like you would see with a stroke. If you interview them carefully, they'll talk about a more subacute onset of symptoms that have happened over a longer period of time. This patient presented with stroke symptoms. We did a head CT, and we can see that there's a low-density mass in the left frontal lobe, and you can see the mass effect. You can see the midline shift to the right. The midline structures are being displaced. There is sulcal effacement, so we don't see any CSF in the sulci, and we see vasogenic edema surrounding the mass. So here's the edema in the white matter, and it's sparing the cortical gray matter. And then we see calcification, this ribbon-like calcification in the mass. And you might see this and think it's hyperattenuating. Is it hemorrhage? Well, it's not hemorrhage because we can see the density is equal to bone. And if we put it on bone windows, you can see that the density is equal to bone. So that's calcification. It's too dense to be hemorrhage. Here we have the T2 weighted image and the T2 flare image, and we can see this large T2 hyperintense mass. It's infiltrating the brain parenchyma. It's causing mass effect. There's a midline shift. There's the sulcal effacement. We have the surrounding vasogenic edema. And we have replacement of normal tissue architecture. So the cortex here, we can't quite make it out. It's very blurry, thickened, and abnormal architecture of the tumor. On the pre and post contrast images, this is T1 weighted image with contrast, and without contrast, and this is the image with contrast. And on the contrast enhanced image, we can see these indistinct patchy areas of enhancement within the tumor. So this tumor does have some enhancement. Finally, on the diffusion weighted images, you can see that the tumor has some restricted diffusion. So we have these bright areas on DWI and corresponding dark signal on the ADC map, and that means restricted diffusion. And when we see restricted diffusion in a tumor, that means it's going to be higher grade. So this was a tumor that had calcification in the mass, so we're thinking oligodendroglioma, but it also has restricted diffusion. So that should make you think about an anaplastic oligodendroglioma, and that's what this was, WHO grade 3. Next case, we have a 22-year-old male with new onset seizures. So that's another common presentation with brain tumors. Brain tumors can cause seizures. So here we have a T2 weighted image and a T2 flare image, and we have a T2 hyperintense bright mass in the right sylvian region. It's affecting the temporal lobe and the insula portions of the frontal lobe. There's mass effect associated with this. So we have sulcal effacement. We don't see the normal CSF in the sylvian fissure and the sulci. We have midline shift to the left, and we have effacement of the right lateral ventricle. So that all indicates mass effect. We have vasogenic edema surrounding the tumor, so this bright signal that's extending out into the white matter and sparing the cortex, that's the vasogenic edema. We have replacement of normal tissue architecture. So instead of being able to see the cortex through this abnormal signal, instead we have this homogeneous intermediate signal that's thickened the cortex and surrounds the sylvian fissure here. So that's abnormal architecture. And the indistinct tumor margin, that's very indistinct here. We can't draw a line exactly around where the tumor stops. Here we have pre and post contrast images, so T1 weighted image without contrast and with contrast, and we have no significant enhancement in the tumor. We have a few foci of enhancement in the sylvian fissure, and those are blood vessels that are enhancing, but the tumor itself does not enhance. On diffusion weighted imaging, this tumor has no restricted diffusion, so we have no bright signal on DWI, and we have no dark signal on ADC. This is very bright on ADC, so that means no restricted diffusion. And this turned out to be a lower grade tumor, diffuse astrocytoma, and it's WHO grade 2. Next case, 26-year-old male. Here we have a head CT without contrast and with contrast. So we can see a low density hypoattenuating mass in the right temporal lobe. It's expanding the temporal lobe. It's causing mass effect, displacing the frontal lobe, displacing the midbrain. And we have vasogenic edema. Here's some of the vasogenic edema in the white matter sparing the cortex. There's no calcification in this mass, and there's no enhancement in the mass on the post-contrast images. On MRI, we have T2 and T2 flare. Again, we have this large T2 hyperintense mass occupying the right temporal lobe. It's expanding the right temporal lobe, causing mass effect, displacing the frontal lobe and the midbrain. The mass has vasogenic edema, so we can see that again on the MRI. Vasogenic edema sparing the cortex. We have replacement of normal tissue architecture. That's particularly evident here on the T2 flare, where we have this heterogeneous signal, and we can't make out the normal brain structures within this mass. It's completely replaced the brain tissue. The margin of this tumor is indistinct, like the previous tumors that we've seen, so it's a little bit fuzzy margins, hard to draw a line exactly around the margin of the tumor, and this is an infiltrated tumor. Here we have T1 pre-contrast and T1 post-contrast, and we can see that there's no significant enhancement in this tumor. A small amount of vascular enhancement around the tumor, but no enhancement within the tissue of the tumor itself. Here we have diffusion-weighted imaging. We have the DWI image in the ADC map, and you can see this is very bright on ADC, so there's no restricted diffusion within this tumor. And that indicates a lower grade, so diffuse astrocytoma, WHO grade 2. Next case, we have a 25-year-old male, and we have a head CT without contrast. So here we have a mostly hypoattenuating mass in the left temporal lobe, and there are some indistinct areas of hyperattenuation within the central portion of the mass. There's some mild mass effect associated with this tumor, some sulcal effacement. When we go to MRI, this is the T2 flare image. We can see that the mass is bright on T2. It's got homogeneous, hyperintense signal on the T2 weighted image, and it's replacing the normal brain architecture, so we can't make out the cortex and the white matter underlying the mass. On the pre and post contrast images, this tumor does have a little bit of enhancement. So if you look in the central portion of the tumor on the post contrast image, you can see some mild enhancement centrally. And on the diffusion weighted image, DWI, we have a curvilinear band of bright signal and then dark signal on the ADC map. So that's mildly restricted diffusion within the tumor, and that indicates a higher grade. So this was a WHO grade 3 anaplastic astrocytoma. Next case, we have a 67-year-old male, so older patient this time. That makes us think about different types of tumors. So we have a T2 flare image, and we have a mass, an ovoid mass within the left frontal lobe and insula, and there's surrounding vasogenic edema. Here's the bright signal in the white matter. It's affecting the white matter but sparing the cortex. So vasogenic edema. We have mass effect with effacement of the sulci and mild effacement of the frontal horn of the left lateral ventricle. And then here's the replacement of the normal tissue architecture. So we can't see the normal cortex underlying this tumor. We have some homogeneous intermediate signal within the tumor. On the pre and post contrast images, you can see there's definitely enhancement in this tumor. So very bright on the post contrast image, and it's heterogeneous enhancement. So on the periphery, we have more enhancement, and centrally we have these areas of no enhancement that represent necrosis within the tumor. This pattern of enhancement should make you think about a higher grade glioma. Here we have diffusion weighted imaging. So DWI, the tumor is bright. In the ADC map, we have dark signal in the tumor, and that indicates hypercellularity. And along with the enhancement pattern, that suggests a glioblastoma, WHO grade 4. Next case, we have a 63-year-old male. We have a non-contrast head CT, and we can see that there's a mass within the corpus callosum here. It's mostly a low density mass with a small amount of hyperattenuation on the margin. There's mass effect, partial effacement of the lateral ventricles, and when we look in the right frontoparietal region here, you can see vasogenic edema. So here's that low density in the white matter. It is involving the white matter only and not affecting the cortical gray matter. So that's vasogenic edema. Next, we have an MRI image, T2 flare, and you can see that the mass is completely replacing the posterior portion of the corpus callosum, crossing the corpus callosum. That limits our differential of what this could be. And we can see that there's replacement of the normal tissue architecture. So we have this homogeneous intermediate signal, and we don't see the normal brain parenchyma through the mass. Here, adjacent to the mass, we have vasogenic edema. So we have the bright edema within the white matter, and it's sparing the cortex. So that's the vasogenic edema. On the pre and post contrast images, we can see that the mass has some enhancement peripherally that's heterogeneous, and then the central portion of the mass has no enhancement, so non-enhancing, probably necrosis within the center of the mass. If we see necrosis in a glioma, that means it's a glioblastoma. So look for that pattern of enhancement. Here we have the coronal post-contrast image showing the mass crossing the corpus callosum, and then sagittal pre-contrast and post-contrast. And again, that pattern of enhancement with central necrosis. On diffusion-weighted imaging, you can see that the portions of the tumor that showed enhancement on the post-contrast also show restricted diffusion. So here's that bright signal on DWI, dark signal on the ADC map. So that's mildly restricted diffusion, and that indicates hypercellular tumor. And this was a glioblastoma, WHO grade 4. And this pattern that we see is also called a butterfly glioma when it crosses the corpus callosum. Next case, we have a 75-year-old female with left-sided weakness. We have a non-contrast head CT. And here we can see that there's an intraaxial mass. The central portion of the mass is hypoattenuating. The peripheral portion is a little bit hyperattenuating. And then there's surrounding vasogenic edema. So again, that low density in the white matter sparing the cortex, vasogenic edema. So that indicates that we're dealing with a tumor here. You can see the mass effect with effacement of the sulci, mild shift of the interhemispheric fissure as well. Here's a T2 flare image. So again, we can see that mass in the parieto-occipital region, and it's extending into the corpus callosum. There's a replacement of that normal tissue architecture. So we see this intermediate heterogeneous signal, and it's replacing the normal brain parenchyma. Here's the vasogenic edema surrounding the mass. So that bright signal on flare, sparing the cortex, and that indicates vasogenic edema. If we look for the tumor margin here, it's indistinct. So we can't draw a line around the margin of the tumor. Very indistinct. On pre and post contrast, here we can see that the tumor has heterogeneous enhancement and again some areas of central necrosis within the tumor. So this is a glioblastoma, WHO grade 4. The other things that can potentially cross the corpus callosum are lymphoma and then rarely tumefactive demyelination. So sometimes we can have a demyelinating lesion that's very large and looks like a tumor, and those can cross the corpus callosum, but they're rare. The main differential is glioblastoma and lymphoma. Those would be the most common things. Next case, we have a 61-year-old female, 2 to 3 week history of worsening headaches and mild right-sided weakness. Non-contrast head CT, we can see there's a mass in the left frontal lobe. We can see the mass effect, the sulcal effacement, the shift of the interhemispheric fissure. The central portion of the mass is low density. Peripheral portion is higher density, indicating hypercellularity. And there's surrounding vasogenic edema here. On T2 flare images, you can see the mass again. There's a replacement of the normal tissue architecture, some heterogeneous signal that's replaced the normal brain parenchyma. Surrounding it, we have the vasogenic edema that's extending into the white matter and sparing the cortical gray matter. And we have an indistinct tumor margin, so fuzzy margin around the edges of the tumor. So it's an infiltrative tumor. Here's the pre and post contrast. So we have the peripheral heterogeneous enhancement, the central non-enhancement and necrosis within the mass. And on diffusion, we have some restricted diffusion within the mass. Bright signal on DWI, dark signal on ADC. That indicates hypercellularity. So we're thinking glioblastoma in this patient. And that's what it is, glioblastoma, WHO grade 4. Here is an SWI image, susceptibility weighted image. So we're looking for susceptibility artifact, which is dark. And this indicates a few different things. Most commonly, this is going to be hemorrhage. So there's probably some hemorrhage in this mass, which is not uncommon with glioblastomas. They can have internal hemorrhage. The other thing you'll notice here that some of the vessels are dark on the SWI image, and glioblastomas can be hypervascular. So some of these dark areas could be blood vessels within the tumor. And then the final thing is calcification that can have susceptibility artifact. But this is a GBM, and this is probably hemorrhage within the GBM. Next case, 41-year-old male. We have non-contrast head CT and T2 flare image. On the head CT, you can see this ovoid area of mild hyperattenuation, so it's about equal to gray matter in attenuation, and we have surrounding vasogenic edema and mild mass effect. On the flare image, you can see this replacement of the normal tissue architecture, that intermediate signal on T2 flare, and the surrounding vasogenic edema. Here's pre and post contrast. On the post contrast image, you can see that there are multiple nodular areas of enhancement, and some of them are heterogeneous with some non-enhancement centrally. When we look at more of the images in this patient, you'll notice that there's abnormal signal in the corpus callosum. So here's hyperintense signal in the splenium of the corpus callosum on T2 flare, enhancement, heterogeneous enhancement in this location on post-contrast, and on the sagittal post-contrast, you can see the enhancement in the splenium of the corpus callosum. So as I was discussing earlier, if something is crossing the corpus callosum, that limits our differential diagnosis. So we're thinking here glioblastoma, lymphoma, or possibly a tumefactive demyelinating lesion. This turned out to be a multifocal glioblastoma, and we needed a biopsy to tell for sure what this tumor was, because this is a little bit unusual for glioblastoma. Most commonly, it's going to be a single enhancing mass, but occasionally we can have multifocal enhancing masses with glioblastoma, and that's what we see in this case. Next case, we have a 23-year-old male, and we have a non-contrast head CT. We have a hyperattenuating mass in the medial portion of the left frontal lobe. It's brighter than the adjacent brain parenchyma, so hyperattenuation, and that indicates hypercellularity. There's some mild mass effect with midline shift of the interhemispheric fissure and mild effacement of the frontal horn of the left lateral ventricle. On the T2 and T2 flare images, we can see that the mass is hyperintense on T2, about equal to cortical gray matter and signal on both T2 and T2 flare. And there's replacement of the normal tissue architecture here again. So we have that homogeneous intermediate signal on the T2 flare image, and there's not very much edema surrounding this tumor. Here we have pre and post contrast, T1 weighted images, and on the post contrast image we can see that there's heterogeneous enhancement within the tumor. Here is the SWI image, and this tumor has no hemorrhage within it, so there's none of that dark signal that we saw with the other tumor. When we look at the DWI images, we have restricted diffusion. It's fairly intense, so hyperintense signal on DWI and hypo-intense dark signal on the ADC map, so that's restricted diffusion. This turned out to be a glioblastoma, and that restricted diffusion tells us that it's a higher grade tumor. Next case, we have a 44-year-old male with a non-contrast head CT. So here we have a hyperattenuating nodular area of tumor, and there's surrounding vasogenic edema. So there's extensive low density in the white matter that's sparing the cortical gray matter. So that's vasogenic edema, and it's surrounding this hyperdense tumor. We definitely have mass effect in this case, so we have midline shift. The septum pellucidum is shifted to the left on both of these images, and we have sulcal effacement adjacent to the tumor, so there's no CSF in the sulci. Here are some normal sulci with CSF. These sulci are effaced, so that's mass effect. Here we have T2 and T2 flare images. On the T2 weighted images, we see that nodular area of hyperattenuation on the CT scan is dark on T2. It has hypo-intense signal on T2. And this is something that we see with lymphoma. So dark, very dense hypercellular tumors can be dark on T2 weighted images. We've got, again, the vasogenic edema that you saw in the CT scan. It's bright on the T2 weighted image, spares the cortex, so that's vasogenic edema. And the mass effect we see again with midline shift to the left. Here we have pre and post-contrast T1 weighted images, and on the post-contrast image you can see that there's nodular enhancement, and it's relatively homogeneous, unlike the glioblastomas that we saw that were more heterogeneous enhancement with necrosis. This is relatively homogeneous enhancement. Here we have diffusion weighted images, so DWI, we have bright signal, and on the ADC map we have dark signal. So that's restricted diffusion. That's something that we see with primary CNS lymphoma in addition to the higher grade gliomas. Here's another patient, 66-year-old female with confusion. We have a large hyperattenuating mass, and there's mass effect, there's midline shift of structures to the right, and there's adjacent vasogenic edema. So here's that low density edema in the white matter, sparing the cortex, so vasogenic edema and mass effect. Here's the MRI, T2 weighted image, T2 flare image, and we can see that there's the large mass here that we saw in the CT scan. There's a replacement of the normal architecture, some heterogeneous signal on T2, and there's surrounding vasogenic edema that's bright on the T2 weighted image and spares the cortex. On the post-contrast image, we can see that there's relatively homogeneous enhancement in this tumor. So we don't see any of that heterogeneous central necrosis that we saw with the GBM. It's pretty homogeneous enhancement. And on the DWI image, we have restricted diffusion in the tumor. So bright on DWI, dark on ADC, so restricted diffusion. And this is another case of primary CNS lymphoma. All right, we'll talk about a few potential mimics of primary brain tumors. So this is a 27-year-old male with epilepsy, and what we're seeing here on the bone window images is ribbon-like cortical calcification. So this is sort of similar to what we saw with the oligodendroglioma, but it's more extensive. And when we look on the MRI, we have T1 pre-contrast and post-contrast. We can see that there's volume loss in the cerebral hemisphere compared to the normal right cerebral hemisphere, and there's extensive leptomeningeal peel enhancement here. So this is classic for Sturge-Weber syndrome, which is facial capillary malformation and associated capillary venous malformations of the eye and brain. So these patients have port wine stains in the face, and they have peel angiomatosis, which is what we're seeing here, this intense enhancement of the pia, and that causes volume loss in the affected cerebral hemisphere and gyral calcification. So that's Sturge-Weber syndrome. It's strongly associated with seizures. These patients frequently have seizures. Next case, 30-year-old female, non-contrast head CT. We have some areas of nodular calcification, and surrounding abnormal attenuation, hyperattenuation, and then adjacent vasogenic edema. But in this case, there's no significant mass effect. We don't have any midline shift or effacement of the ventricle. So we got a CTA. So we injected contrast and did a CT of the head during the arterial phase, and you can see here that there's a large tangle of abnormal vessels that are enhancing. So this is a nidus of an arteriovenous malformation. Here we see an enlarged feeding artery. So this is one of the left middle cerebral artery branches. If we compare it to the right MCA, this is enlarged. So that's an enlarged feeding artery, a nidus, and then here we have the draining vein, enlarged draining vein that drains to the superior sagittal sinus. So occasionally AVMs will have calcification, so that's something to remember if you see calcification in something that looks like a tumor. Another thing that can be a big mimic of brain tumors is stroke. So I just want to go over briefly the evolution of stroke on CT. So here's a patient who had a right MCA territory infarct, an acute infarct. This is very early, 6 hours after onset of his symptoms, and we have very subtle changes in the brain here. So loss of gray-white differentiation diffusely. Here we can see the left lentiform nucleus. Here the right lentiform nucleus is hypodense. Same with the cortical gray matter in this area. The cortical gray matter is hypodense, so we have loss of gray-white differentiation. That's cytotoxic edema, acute infarction. Here it is at 12 hours. So now it's a little bit more obvious, a little bit more hypodense. And then over the next few days, you can see how obvious it becomes. It becomes very hypodense. And at 5 days, it's very, very hypodense, and we have mass effect. But what you'll notice about this is that it's involving the cortical gray matter. So compared to the vasogenic edema, this cytotoxic edema is affecting the cortex, and the cortex is hypodense here. Here it is on MRI. So on the diffusion weighted images, this is abnormally restricted diffusion in the infarct. But if you look, you can make out the normal structures here. So here's the lentiform nucleus. Here's the cortex of the insula. So this is edematous brain tissue. This has not been replaced by tumor. This is abnormal brain tissue that has infarcted. Here it is on T2 and T1 weighted images. So again, edematous basal ganglia, insular cortex, and the cortex of the temporal lobe and insula and frontal lobe. So we've preserved the underlying architecture of the brain tissue. We just have edema in the brain parenchyma. Here it is at 12 weeks. So now we have encephalomalacia, very hypodense, equal to CSF in density, and the mass effect has resolved. So that's the evolution of the infarct. Here's a comparison of stroke versus tumor on CT. Here's an acute infarct, so hypodense, affecting the gray matter. Here's a tumor. So we have a mass, we have mass effect, and we have vasogenic edema. This edema is affecting the white matter, and it's sparing the cortical gray matter. So this is vasogenic edema associated with the tumor. This is an acute infarction with cytotoxic edema. Here we have stroke versus tumor on MRI. So here's an acute infarct in the left MCA territory. You can see that the insular cortex is edematous here. It's swollen, bright on T2. And here's the tumor. Here's the replacement of the normal architecture, the mass effect, the midline shift, and this is the tumor. And again, here's another tumor, very mass-like, mass effect, replacement of the normal architecture, compared to the infarct where you can make out the underlying cortex and white matter. Here it is on diffusion. This acute infarct has intense restricted diffusion, and these tumors have no restricted diffusion. Another thing that can be very tricky is subacute infarcts. So here we have an example of an acute infarct on MRI. This is day 1, so we have edema, hyperintense signal on T2 flare, swelling of the brain parenchyma, restricted diffusion, and that is an acute infarct in the left frontal lobe. Now we got a follow-up brain MRI 2 weeks later on day 15, and look at what's happened here. So we have some dark signal now, which is petechial hemorrhage, and we have surrounding vasogenic edema. If we look at the diffusion-weighted images here, though, there's no restricted diffusion. So it's a little bit bright on DWI, but it's also bright on ADC. So that's T2 shine through. So the restricted diffusion has resolved here. Now, if we go and look at the post-contrast image on day 15, so this subacute infarct demonstrates very heterogeneous enhancement. So this almost looks like the glioblastomas that we saw earlier, where we have the heterogeneous enhancement in the central areas of non-enhancement and the surrounding vasogenic edema. But if we compare it to the diffusion image on day 1, we can see that this tissue that's enhancing is exactly the tissue that was infarcted. So we know that this is a subacute infarct, and it has heterogeneous enhancement. So if you're ever worried that something might be a subacute infarct, what you can do is get a follow-up scan in about 1 month, and the enhancement in the tumor should resolve. So here's an example of a subacute infarct with enhancement. So here we have bright on T2, bright on flare, and pre-contrast T1, post-contrast T1, and you can see this very heterogeneous enhancement on the post-contrast image. There's not very much restricted diffusion, if any, in this tumor, and there's some cortical petechial hemorrhage. Now, if we compare this stroke at day 14, this is the subacute stroke that we were looking at earlier, we have a follow-up scan from 8 months later, and you can see what's happened. We've developed encephalomalacia. So this edema and swelling has resolved, and now we have volume loss and encephalomalacia in this area. So this was a subacute infarct. Okay, so finally we're going to talk about metastasis. We don't have very much time, but luckily metastasis is more simple than gliomas. So what we look for with metastasis is discrete round, solid or ring enhancing lesions in the brain. Sometimes we'll have a single lesion, often we'll have multiple lesions, and they tend to be randomly distributed about the brain, and frequently there's surrounding vasogenic edema, and restricted diffusion may be present in the lesions. So here's a 43-year-old female with breast cancer, T1 pre-contrast, T1 post-contrast. We have a large, solid nodule of enhancement in the brain parenchyma, or round enhancing lesion. On T2 and T2 flare, you can see that there's surrounding vasogenic edema affecting the white matter, sparing the cortical gray matter. And on the diffusion-weighted image, there's mild restricted diffusion, so some dark signal on ADC. And when we look at the rest of the brain, we see that there's an additional lesion in the left cerebellar hemisphere that's enhancing and has adjacent edema. So this is metastasis from breast cancer. Next case, we have another patient with breast cancer, 59-year-old female, and this is showing that sometimes the lesions can be cystic. So here we have a large cystic lesion in the right occipital lobe, and the fluid is bright on T2. It suppresses on flare, and we have additional lesions with vasogenic edema throughout the brain. Here on pre-contrast T1 and post-contrast, this has a rim of enhancement all the way around. So that's a large cystic metastasis. Here we have some smaller cystic metastases and some solid metastases. So these are all metastatic lesions from breast cancer. Here on the diffusion-weighted image, we do have mild restricted diffusion in the wall of some of these lesions. Next case, 51-year-old male with lung cancer. We have a large lesion in the cerebellum. We have a solid nodular component and then also a cystic component in this lesion. So we have solid enhancing tumor and then a cyst with enhancement of the wall. And that's a metastatic lesion from lung cancer. If we look on CT, this is actually hyper-attenuating on the CT, and that's because it's hypercellular. And we also see that on the diffusion-weighted image. So restricted diffusion, bright on DWI, dark on ADC. Hypercellular tumor, metastasis from lung cancer in the cerebellum. Now we can look around the rest of the brain. I don't see any metastasis in the brain parenchyma, but the other place we need to look is the bone. So in the skull, the calvaria, we have lesions that are bright on T2, dark on T1, and have enhancement on the post-contrast. So those are bony metastatic lesions in the calvaria. And these are actually sometimes easier to see on diffusion. So here's the diffusion weighted image, and here you can see these bony metastases very well on diffusion. Here we have an additional lesion in the skull base. So the normal signal in the clivus is bright on T1, and here we have this dark lesion on T1. It's bright on the T2 fat saturated image in the left side of the clivus, and here it is dark on T1. So multiple bony metastases in addition to the cerebellar metastasis. Here's an additional case, 55-year-old male with melanoma. And the special thing about this case is that the patient has melanoma, and when we look at the T1 weighted non-contrast image, these lesions are bright on T1 without contrast. So they have intrinsic T1 shortening, and that's something that we can see with melanoma because of the melanin. The melanin can actually be bright on T1 weighted images. And here on the post-contrast image, there's maybe a little bit of enhancement of these lesions. Here we have a sagittal image, so a few more T1 hyperintense lesions scattered throughout the brain, and these are melanoma metastases. Here you see the vasogenic edema surrounding the metastasis, and here on SWI you can see that there's some hemorrhage within these metastases. That dark signal on SWI is hemorrhage. Another case, we have a 55-year-old female who presented with acute encephalopathy. We have on T2 flare, multiple T2 hyperintense, small round lesions scattered throughout the brain. And on the SWI image, you can see that these are hemorrhagic, all of these innumerable hemorrhagic lesions scattered throughout the brain. On T1 pre-contrast, many of them are bright, but on the post-contrast, you can see that there's definitely enhancement, and there are innumerable lesions throughout the brain, and these are hemorrhagic metastases from lung cancer. Another thing that we can see sometimes is a frank hematoma with a metastasis. So sometimes we have a large amount of hemorrhage. This patient presented with a hematoma in the left temporal lobe, and for the workup of the hematoma, we do a brain MRI with and without contrast to look for an underlying enhancing lesion. So here you can see on the pre-contrast, this area is intermediate signal intensity, and on the post-contrast, there's this nodular enhancing lesion at the margin of the hematoma, and this turned out to be a metastasis from renal cell carcinoma that caused a hemorrhage in the brain. Potential mimics of metastasis, we have a few. Brain abscess is one of them. So when we look in this patient on the T1 post-contrast image, we have a ring-enhancing lesion in the right temporal lobe, ring-enhancing and no enhancement centrally. When we look on diffusion, the fluid within this lesion has restricted diffusion. And what that means is that the fluid is very thick and viscous, and that means that it's pus. So this is an abscess that contains pus, and the pus has restricted diffusion. So if you see restricted diffusion in the fluid, think about abscess. Here's a metastasis for comparison. We have a ring-enhancing lesion in the right temporal lobe, and we have no restricted diffusion. Here's another case, 63-year-old female with left leg weakness. We have multiple lesions that are hyperintense on T2 flare and hypointense on T1. And some of these are demonstrating some ring enhancement, although some have incomplete rings of enhancement. When we go more superior in the brain, we see here's a T2 hyperintense lesion that does not enhance. Now, this is not something you see with metastases. Metastases enhance on post-contrast images. So if you have no enhancement on the post-contrast image, you're not dealing with metastasis. Here's a coronal image that gives us another clue. So here's an open ring of enhancement, or a C shape of enhancement. And when we see this open ring of enhancement, we need to think about demyelinating disease, because that's the most likely diagnosis. And this patient had confirmed multiple sclerosis. This patient was treated with steroids because they were going to do a brain biopsy and they wanted to relieve her brain edema. And they treated her with steroids, and 6 days later you can see that this enhancement resolved after steroids. So that further confirms that this is demyelinating disease which responded to the steroids. Here we have an 85-year-old female with stroke, visual changes, confusion, and what we see on the SWI image is that we have innumerable foci of susceptibility artifacts scattered throughout the brain. This is similar in appearance to the hemorrhagic metastases that we saw earlier, but we don't see any lesions on the flare, and when we give this patient contrast, we have no enhancement. So what we're dealing with here is cerebral amyloid angiopathy. And this is something that affects typically elderly patients, and what we're going to see is these innumerable foci of susceptibility artifact, which are microhemorrhages in the brain. We're going to see chronic small vessel ischemic changes in the white matter, these areas of hyperintense signal in the white matter, and we're going to see some volume loss. And this is cerebral amyloid angiopathy. And finally, our final mimic of metastasis, we have here a 21-year-old female with seizure, and this is a non-contrast CT of the head. We have a hyper-attenuating lesion in the left occipital lobe, no significant edema surrounding the lesion. When we look on T2 weighted images, we have some bubbly T2 hyperintensity in the lesion, and we have a dark rim, a rim of hypointense signal surrounding the lesion. When we look on SWI, we have susceptibility artifact. So this is classic for a cavernous malformation. And here we see on T1 pre-contrast, there's some areas of T1 shortening. On post-contrast, we have a few areas of enhancement. And enhancement is variable with cavernous malformation. It may or may not be present, but this is a cavernous malformation, and that can mimic metastasis. These are malformations that are composed of dilated thin-walled capillaries, and they have microhemorrhages, and that causes a rim of hemosiderin to form around the lesion. And the one additional thing to remember about these is that they're often hyperattenuating on CT. So if you see a hyperattenuating lesion in the brain parenchyma in an asymptomatic patient, think about cavernous malformation. You can do an MRI to confirm that. And that's the end of my talk. Those are the references. If you have any questions, please feel free to ask.